Good evening, this is Dr. McSherry. It is 8 p.m. on August 19th, 2013. Tonight we're going to be doing a sample mock prep webinar. It's being recorded for the 2013-2014 candidates on the website, and this is just to get you an idea of what type of test questions are on our webinars nightly. Dr. Wall's OBGYN board prep is the only mock board review that concentrates on questions on the 2013 mock exam. This is strictly not a didactic course. It's clearly a course where you'll be able to recognize your vulnerabilities and gear up your study for the Part 3 Year 6 exam. This is going to provide you up-to-date information on the latest practice guidelines and recommendations and best practices and provide you with well-rounded funded knowledge for the examination. Our exams are objective single best answer multiple choice questions, and they're constructed to be thought-provoking. So many questions will have all the possible answers may be plausible, but only one is going to be correct. Now, a little bit about the mock examination. The examination content for the MOC is 250 question selectives chosen by the diplomat, and you'll have a chance to choose on your application what 250 question test sets that you would like to take. The exam is only 105 minutes, so you practically have about a minute per question, which is pretty good. I mean, a little bit more than a minute. The questions will be multiple choice, as I stated, and one best answer type will be based on common clinical problems. There's no physiology on the exam that I'm sure of, no specific oncology, choosing what stage of cancer. So I think the exam is going to be very straightforward. The test selectives you get to choose from on your application, selective test A, it's OB/GYN office practice and women's health, OB only, GYN only, and office practice and women's health. And selective list B is the same thing. So it's OB/GYN office practice and women's health, OB only, GYN only, office practice and women's health. You can actually sign on to ABOG's website and do a practice test at www.abog.org. I looked at their exams. They're reasonable. They're very similar to our exams. I think our exams are a little bit harder, so to gear you up for the exam. It's representative pretty much of all the questions that will be on the exam on the website. The webinar study sessions, these are online exams will be given every third or fourth webinar online. Nightly questions will be discussed in an open forum. So tonight we're going to be doing a sample of about 10 questions. All candidates involved in the webinars are encouraged to ask questions and full understanding is not achieved. Exam and answer key of the actual test will be distributed to each candidate after the exam. So you can go through the exam on your own, look at your answers, look at the explanation, because you'll be sent the note pages also. October through December webinars will be Monday through Thursday, and I will put the mock prep candidates in with the written candidates because we will start a written course in the first week of October, and it'll go on through June. So unless we have a request, we may do a separate mock prep webinar. But during the summer, July, September, and August, we do the mock prep webinars on a bi-weekly basis. Okay, we have several candidates here tonight, so I'm going to go ahead and call on one of our candidates to go ahead and read some test questions and participate in the webinar. So I see, Elvira, you're up here first, so I'm going to go ahead and call on you first. I'll be read about 3 questions, and then we'll go on to somebody else. So the candidates that are signing on are the diplomats that are going to be taking the exam, and they can see how these webinars are run, which is pretty important. Hi, Elvira. How are you?
I'm doing good. How about you?
Good. Did you review this exam at all?
Yeah, I actually did those questions myself.
So. Did you? Well, that's good. You gotta. But for the actual mock prep webinars, we don't give samples of the test out prior to webinars. We want everybody to learn and not be able to study the questions beforehand. So we're going to go ahead and do this exam. I'll put up the first question. Okay, go ahead and read the question and read all the choices and tell me what you thought the best answer was.
Which of the following cardiac conditions requires prophylactic antibiotics to prevent subacute bacterial endocarditis? Choice A, mitral insufficiency. B, repaired ventricular septal defect. Choice C, history of previous endocarditis infection. D, mitral valve prolapse with valvular regurgitation. And choice E, repaired tetralogy of Fallot 10 years ago. History of previous endocarditis infection, this will be the choice, that will be the answer that will require prophylactic antibiotics.
Now, what other cardiac conditions require antibiotics?
Those unrepaired cyanotic heart conditions. Also, there is a condition, patients with prosthetic cardiac valve, they also will need prophylaxis. Also, there is a repaired cardiac defects, but if they were repaired within 6 months, and there is one more option. It's a repaired congenital heart disease, but with
it's right on the bottom of the slide.
It's a residual defect, yeah, so I yes. So it's a residual defect at the site that adjacent to the repair site. Those conditions will require antibiotic prophylaxis.
Right, and it's important to know what antibiotics you also give too, because that could be a question that's asked on the MOC also. And you can give ampicillin or ceftriaxone, and if they're allergic, that's a good question. Clindamycin 600 milligrams IV, and oral amoxicillin is an option, but you don't want it. You can give oral clindamycin if the patient had an allergy to penicillin. Yeah, and then a lot of candidates get confused, or diplomats may get confused regarding the mitral insufficiency, mitral valve prolapse. You don't give antibiotics for those conditions, and patients that are going for a straight vaginal delivery or a cesarean section in the absence of an infection, you don't need to give it either. Only if they have an infection, then. But we're giving the antibiotics anyway, right, for an infection.
Right.
So it's being covered. So you're killing two birds with one stone in a situation like that. Okay, let's do number 2. Go ahead.
A 20-year-old presents with an indurated Bartholin gland. On examination, it's non-fluctuant. What is the next best step? In this case, so choice A, wart catheter, B, incision and drain, C, antibiotics, D, observation, and E, marsupialization. The right choice will be observation, because at this point, in the question, there is nothing that said that it's infected, so basically it's not an abscess. Even for cyst, Bartholin gland cyst that is not infected, we don't give antibiotics, we just observe. And marsupialization, that will be the option only if it's recurrent.
Right, exactly. And what are some of the options to treatment of a Bartholin gland abscess? Although this is not an abscess, it's maybe starting into something, and you can observe these. And this one, definitely, this clinical picture is an observation. How do you treat a Bartholin abscess?
Bartholin abscess, in particular, if it has symptoms like pain on palpation, when patient has fever, erythema, difficulty sometimes urinating, sometimes even difficulty defecating, ambulating, sitting.
Right, and that's all reasonable.
Then it's going to be incision and drainage with insertion of the wart catheter. Now, we need to add antibiotics only if there is a sign of cellulitis.
Yeah, and that's important. And where do you make the incision when you're doing a Bartholin abscess drainage?
And incision we are making on the, it's the internal part of the labium majus.
Well, no, you want to make it at made near the hymenal ring, or at the
hymenal ring.
Yeah,
yes.
Exactly, at the duct orifice. Okay, now what happens if the patient's over 40? What do you have to worry about?
Then we need to make sure that we rule out Bartholin gland adenocarcinoma.
There you go.
Or if it's postmenopausal woman, then we need to biopsy it.
Absolutely. You're absolutely right. Good. And they recommend, now this is kind of interesting because some textbooks actually recommend incision, excision of the cysts if it's recurrent, and then I've also read too that you can do biopsy, but I think biopsy is a little bit better for the patient and has less morbidity because these things really, really bleed. So unless you're actually suspecting your biopsy shows that it's carcinoma, then you pretty much biopsy is a reasonable option. Okay, number 3.
What is the most common presenting sign in a patient with a pulmonary embolus? A, tachypnea, B, dyspnea, C, pleuritic chest pain, D, hemoptysis, E, apprehension. The most common presenting sign is tachypnea.
Okay. Good, exactly. And on the bottom here you can see all in order, not really much in order, but it really goes through the percentages. 54% are actually tachypnic. They have quick breathing, and they're breathing very, very at a fast rate. Some have rales, decreased breath sound. 70% of patients had tachypnea, 51% rale. So those are in the top 3, and tachycardia is up there too. And then a fourth heart soundness. Remember, the best diagnostic study for a pulmonary embolus is?
It's a CT angio.
Spiral CT overall, but the most sensitive test would be your angiogram, and that's a very, very strong,
CT.
Spiral CT pretty much, but also for pregnant patients too. Okay, number 4.
Which of the following is least likely presenting symptom associated with pulmonary embolism? A, angina, B, pleuritic pain, C, cough, D, leg swelling, E, palpitations, and it's going to be angina.
Good. Good, angina.
This is the least likely.
Yeah. Right. Right, and you're right. Most common symptoms are dyspnea at rest with exertion, pleuritic pain, cough, greater than 2 pillow, orthopnea, and so on. They're on the bottom here. 4% of patients had the angina. It's really, really, really low. Okay, so A is the right answer there. Good. We'll move on to the next question, and then I'll have you read one more, and then we'll move on to one more candidate. We'll do 10 questions tonight. Okay, number 5.
Which of the following has the highest relative risk for breast cancer? A, more than 2 relatives with breast cancer. B, live birth less than 20 years old. C, age of menarche less than 12 years old. D, history of 2 breast biopsies. And it's going to be more than 2 relatives with breast cancer.
Good. Good. And the Gale model, too, this is around regarding the Gale model. And more than 2 relatives with breast cancer, absolutely. Your relative risk is actually pretty high. It's 4.1 to 6.8. Yes. Okay. Well, Elvira, you did a good example of reading the questions tonight. Thank you very much. And I'm going to move on to Rachel. Thank you.
Thank you.
Hi, Rachel. How are you?
Good evening. Great, Dr. McSherry. How are you doing tonight?
Good, good. I should call you Dr. Consoli. I'm sorry.
You're fine. You're fine.
All right, number 6. Go ahead. I'll let you go to 10, and then we'll conclude our webinar for tonight. Number 6.
Number 6, which of the following corresponds with the best management of a patient with mitral valve stenosis in labor? A, beta blockers, B, avoid induction of labor, C, fluid restriction, D, avoid regional anesthesia. So they're saying which is the best management. And I would say the answer is C, fluid restriction.
Right, absolutely, and that's what they recommend. Strict attention needs to be paid to avoid fluid overload. The epidural is great for these patients in labor. You've got to be really careful. And I think with aortic stenosis, it's actually opposite. You want to keep them on the wet side with aortic stenosis. So a lot of people get confused on that. Rheumatic endocarditis is 75% of the cases of mitral stenosis. And they could also ask you the most common complaint. Which of the following is the most common complaint of mitral stenosis? It's going to be dyspnea, and that's secondary to pulmonary venous hypertension. Good. Okay, number 7.
Okay, number 7. Which of the following cardiac conditions would be a contraindication to pregnancy regardless of functional class? A, right-sided obstructive lesions, B, atrial fibrillation, C, aortic root dilation of 2 centimeters, D, pulmonary hypertension, and E, 30% obstruction of the anterior descending coronary artery. And actually you gave us once a list, and the answer is C. D, pulmonary hypertension.
Good. Good.
Yep.
Absolutely. And pregnancy is also contraindicated in women with certain cardiac conditions. And it says regardless of functional class because maternal risk of death is so high, and then they go pulmonary hypertension, severe systemic ventricular dysfunction, aortic root dilation, and severe left-sided obstructive lesions. Boy, this is a cardiac test if I've ever seen one. And we're talking about pulmonary embolism. So actually the questions on the actual mock prep webinars are divided into OB, GYN, office, and this test tonight is a little bit mixture so you can see the kind of questions that are on the webinars for all the diplomats listening. Okay, number 8.
8. Oral contraceptives decrease the ovarian production of A, androstenedione, B, DHEA, C, FSH, D, LH, and E, estradiol. And the answer to number 8 is A, androstenedione.
Right, and this is a little bit more of a physiology question that'd probably be more so on the written board exam for the part 1 of written board. So with this question, they could ask you that. They may ask you a little bit more of a clinical scenario when you would start oral contraceptives. But just for mechanism of action, it doesn't hurt to know this. I mean, we're practicing OBGYN. Inhibition of the mid-cycle LH surge from the pituitary, and thus preventing ovulation and alteration of the cervical mucosa. This is a good question to ask you. Oral contraceptives decrease which sexually transmitted disease? Caught you off guard.
That's right. No, that's fine. I actually, it's, I know it's either chlamydia or gonorrhea, but I know, I think it's chlamydia is the cervix and gonorrhea is the one in the tubes.
Right. So which one does it decrease? Does it decrease chlamydia or gonorrhea? Actually it decreases gonorrhea because gonorrhea actually lives in the tubes. And with the oral contraceptives, as I just mentioned, is they increase the cervical mucus.
Right, okay.
There you go. Right. Okay, number 9.
9. The best treatment of a cervical pregnancy at 7 weeks gestation in a hemodynamically stable patient is A, hysterectomy, B, uterine artery embolization, C, D and C, D, methotrexate, and E, hypogastric artery ligation. And the answer would be D, methotrexate.
Cervical pregnancy at 7 weeks. Yeah, hemodynamically stable patient, that it would be a definite reasonable option to be methotrexate. If it was a hemodynamically unstable patient, we'd probably have to do some kind of surgical intervention. And if you couldn't get the bleeding under control, common sense would be an abdominal hysterectomy. And that's what they go through here. And this is actually a paragraph that was summarized from one of our textbooks, which is Tillin's 10th edition, chapter 34. Now, do I recommend that all the diplomats go out and buy the Tillin's if you don't have it in your library? Probably you don't need it. But for the people that are studying for the oral and the written, definitely. Tons is a good supplement or a good textbook to have. And also, what textbook are you studying from for your exam? Are you using
Williams
Tulane?
Gynecology.
Yeah, Williams is another good textbook. Okay, last question for tonight, Rachel. Go ahead.
Okay. Great. Which ovarian cancer resembles cervical glands? A. Mucinous, B. serous, C. Hyla cell, D. granulosa cell, and E. sertoli-Leydig. And the answer to number 10 is A. Mucinous.
Good, excellent. Mucinous tumor. What are some other epithelial tumors that you can think of?
Other epithelial tumors, there's a bunch of them, and
which are the common ones that you can just think of off the top of your head?
Let me just see here. Do we have them here?
No.
You mean like benign?
Well, not benign. We're talking about or cancer. So,
excuse me. So serous cystoadenocarcinoma, Hyler cell.
Okay, Hyler cell is not going to be an epithelial tumor.
Serous is epithelial.
Serous, right. Serous histology resembles the lining of the fallopian tube. And then your mucinous, what we're talking about here. Your endometrioid resembles the endometrial lining. Your clear cell and transitional cell Brenner's histology resemble the. So those are your big epithelial tumors. And of course, you got your germ cell tumors and sex cord stroma tumors. We can get into those on another question. But there's definitely no staging on the exam. So we're going to actually stop here for a recording for the mock webinar. And thank you, Rachel, for participating tonight. It's going to be great. Thank you very much.
Thank you.
Okay. Well, this ends the mock prepinar sample that's going to be posted to the website on 8/19/2013 at 8:22 p.m. And I want to thank all for coming in tonight and listening to our little webinar that we had, posting a recording for the website. And thank you again for being here. And I want to hope the diplomats want to sign up with the MOC mock prep webinars. We're going to be covering a lot of test questions. We cover probably up to 25 every night. Okay, take care. Have a good night. And thank you for listening.